Hopefully you all have a buffer enough to really be okay. What does that mean? You say it like it's like that to me and then you connotation. I don't know what that means. Yeah. All right. I got nothing. I didn't see it right now, so. Well, what I do know is about the heart and great vessels. I do know about that. All right. All right. Any questions from you actually from those pneumothoraces? All right. How do we diagnose attention? Ultimately, bottom line, clinically. Clinically. Okay. Regardless of what the X-ray looks like, we see a pneumothorax, and they're hemodynamically unstable. That is a tension pneumothorax. Okay. If the pneumothorax and the structures are shifting, we can call it a tension pneumothorax because you're going to treat it because they're on their way. But make sure you diagnose it clinically. Okay. All right. Don't get tripped up by the little medial scapular border edge. Don't get tripped up by the skin folds, the walls of the blebs, or sorry, the bullae. One's a bleb, one's a bullae, one's small, one's big. We'll see that here in the lectures. Don't get tripped up by those. Remember that radial opaque line has to go along the walls of the thorax in order for it to actually be the pneumothorax because it's that visceral pleura that's going through there. Yes, you can have fluid and air depending on the mechanism of injury. Lung markings, right? Absence of lung markings. I think that's a pretty down and dirty review of pneumothoraces. Remember what your EFAS looks like, right? You got beach, ocean, sky. You're relaxed. You're not worried about it. Sipping a Mai Tai, chilling because the patient doesn't have a pneumothorax. Barcode sign. Oh crap! Right? They have a pneumothorax. So, all right. Let's continue on through the heart and great vessels. We talked about pneumothorax, which is air in the thorax where it's not supposed to be. Now let's talk about pneumomediastinum, which is air in the mediastinum that's not supposed to be there. Okay? This is where some of these other things we talked about will come into play. Right? 1 in 3 patients who end up with pulmonary interstitial emphysema end up getting a pneumomediastinum. Why? Well, go back to that CT picture that we looked at. Look how close where this air is at and these vessels is to the central structures in the mediastinum. It's right next to it. Right? A lot of times your pulmonary interstitial emphysema is sitting right in these areas. Here's the aortic root up here, or aortic arch coming at us. Right? It's really close to all that, so it's really easy for that air to get into the mediastinum. So that's why 1 in 3. 3 and 4 will involve a pneumothorax. Again, why? If I have air somewhere in my chest cavity that's not supposed to be there, it's probably eventually going to make its way out and it can cause a pneumothorax. Okay? Most common causes, though, is going to be trauma. I don't know how most common on there, so there can't be the most common question, but I want you to know trauma is what we're thinking about for pneumomediastinum. And then what are we looking at? Big fancy words for radiolucent. Linear streak-like lucency with a thin white line paralleling the left heart border. What? We'll look at it on pictures. Okay? You can also have linear streaks of air parallel to the spine. And the key thing for you guys here, one of the things that jumps out the most once you learn how to see it, is the continuous diaphragm sign. So up until now, we've had our hemidiaphragms that we can make out really nicely. But when you get to the center where the heart and the spine is, it kind of ends. And you see the vertebrae, you see the heart, and you don't actually see the diaphragm. It almost looks like the spine is blocking the rest of the diaphragm. The diaphragm doesn't stop there, it goes all the way through. You just can't see it because of the density of the vertebrae of the spine. However, when I stick air in there, you will actually be able to trace the mediastinum all the way through. And that'll be one of your signs that there's a little bit of air hiding behind there, allowing that to pop just a little bit more. And we'll see what that looks like as well. Okay. So focus on your normal image. what I was talking about here. Look at my hemidiaphragms. They come up and they stop at the spine, or at least it appears that they stop at the spine. I can't trace that through the spine there. There's no line there. There's not supposed to be. But when I have a continuous diaphragm sign, and I can trace it all the way through, that is one of the signs that there is a new mediastinum on X-ray. Can everybody see on that second picture, I got the black arrow too, how you can actually trace that diaphragm all the way through? One straight line. If I was looking at the crayon, I can go one side all the way to the other. Here I can't do that on my normal. So whether you're concerned about a new mediastinum or not, if you have that continuous diaphragm sign, you should be, now it should be on your differential, it's there. Here's how it looks on CT. It gives you a little bit better picture of it, right? So I have air between my heart and my diaphragm. I have air here in the pericardium and air up into my great vessels up in the upper part of the mediastinum. Air underneath my heart here, air in the pericardium, and air up in my greater vessels. We're going to talk about another condition called pneumopericardium, which is almost the exact same thing as pneumomediastinum. The difference is one has air just in the pericardium, and one has air above the heart into the great vessels. Once it goes up into the great vessels area, like here on this CT, that's where we have a pneumomediastinum, because now it's including more than just the pericardium. And that's kind of my cutoff when I'm looking at things. Now this X-ray, very subtle, but this has a continuous diaphragm sign. We'll look at better X-rays that shows the air in the pericardium versus the mediastinum, and why, and other tips and tricks to go. When do I jump from pericardium to mediastinum if I'm making a diagnosis? There's going to be other signs that we can give you or that you can see on X-ray that will help that stand out. Good lead-in, pneumopericardium. More common in peds and adults. Same concept though, right? Penetrating injuries, trauma, could be spontaneous or iatrogenic. Iatrogenic means what? Caused by us, right? Caused by the hospital. Ventilator, another ventilator mishap potentially, right? Intubation, complications, and multiple reasons that we can cause it. Thinking there's a pneumothorax and shoving a needle deep into something that doesn't need to, and then you hit the lung, right? There's multiple ways that can cause it. Iatrogenic, that's just what that means. All right. Don't worry about the neonates and highly membrane disease. It's like a differential type thing. You'll learn that more in peds. Rare to have air in the pleural space enter the pericardium unless the pericardial defect is present. So this does not become typically pneumothorax leads to pneumopericardium unless there's a pericardial injury, because that's a sac that contains the heart. Just because there's air in the pleural space, there's a pneumothorax, there's really no way for that air to get into that pericardium unless there is damage or a hole or something in that pericardium to allow it to go in. However, you can go the other way and start with pneumopericardium and then be concerned for a pneumothorax. Why? Because in order to have a pneumopericardium, there has to be some kind of damage to the pericardium. So we already have that entryway and exit way on the X-ray. So what I'm saying is if you see both, it wasn't pneumothorax leading to pneumopericardium. It was the other way around. The pneumothorax is a sequela of your pneumopericardium or pneumomediastinum. Okay? You're going to see the continuous lucidity circles the heart. We're going to take a look at pictures of that, and that's that key point. It extends no higher than the root of the great vessels. That's that difference marker. That's that line, okay? The pericardium only encircles the heart. It does not encircle all the great vessels. Yes, CT is often necessary to diagnose it, but we're going to learn how we can see it on X-ray, and then we're going to learn other tips and other things with our process to look at to end up suspecting that one of these things might be going on. Okay. Here is one of the best X-rays I could find to really stand out with what a pneumopericardium looks like. Okay. So again, here's my normal. Take a look at the normal first. Don't jump to the big shiny toy. Take a look at the normal first. Okay. I have the heart leading right into lung tissue. If I were to ask you on this normal image, show me where the pericardium is, you can't pull that out. You have no idea where the heart ends and where the pericardium begins, because it's all just one grayish kind of blob of organ and blood and tissue. But on my pneumopericardium, I have air in the pericardium. Now I have this radioopaque line, and it's sandwiched in with a radiolucent line right here. Now I can say, where's my pericardium? You guys like, right there? Because the air is separating it from the heart, because there's air in the pericardium. Same thing on this side here. I have this radiolucent line coming down that's not typically here on this side, on the normal. Okay? So that is how you can tell there's a pneumopericardium on X-ray. This arrow here, right, this is your main aorta, ascending aorta kind of projection of that. And really, so this is where your great vessels are, right? So if I have my heart, and it comes up to my, if I do it backwards, left ventricle, left atrium, pulmonary vasculature, okay, boom, like right in here is my cutoff. Anything above here, air over here, or air over here, right, that's going to lead to my mediastinum as opposed to just pericardium. But if I can just encircle just the main heart area, with my black line and my pericardium, then we're just at a pneumopericardium. Go ahead.
How does the air from the surrounding lungs get into the pericardial sac, and then does it come with afterwards, or am I thinking of it wrong?
So you're thinking it wrong. What I just said with the last slide, right? It's not the air from, so let's say there was a pneumothorax. Pneumothorax doesn't cause pneumopericardium. The pneumopericardium happens first. So likely what happens in most of these patients is there's some kind of trauma that caused a wound within the pericardium, probably damaged lung as well, or if it was trauma, like a penetrating trauma from the outside, a stab, a bullet, a rib fracture from like a direct impact trauma, right, a blunt force trauma that fractured the rib, caused a hole and a damage in the pericardium, allowing the air to get in, likely from other lung tissue as well. Okay? Which is why a lot of times, which is why 3 out of 4 of these patients, 75% of these patients, will also have a simultaneous pneumothorax. Okay? They will also have a simultaneous pneumothorax. Do y'all see the simultaneous pneumothorax on this film? I'm showing you. There's that one right there. And then let me look better, like you guys have the screen up. Yep, and then I will buy, I will buy potentially as well this guy right here and right above it. Potentially. Hard to tell because it's right behind the rib a little bit, but I do have that thoracy shaped kind of line, and I have no lung markings up here, and then this one here though I have right here for sure, and no lung markings up here. Okay? Likely I need a CT to really kind of pull out, is that a rib fracture there? Maybe, right? But then I got my medial border of my scapula here, so that's medial border of the scapula. These could be skin folds too. I don't know. I need to see the patient to really know. But this guy right here, definitely my pneumothorax. So it wasn't that the air got from there into the mediastinum that was also pericardium that was simultaneously damaged. Okay? Yeah.
Would we hear with auscultation anything unique?
Not really. Not really, because this isn't within the heart, right? So your cardiac exam is going to be normal. Right? The only thing you'll get abnormal in your auscultation is you might get decreased or absent breath sounds where the pneumothorax is, but as far as for the pneumomediastinum or the pneumopericardium, your physical exam is likely going to be normal because the issue is not within the lungs and the issue is not within the heart, the valves, which is what you're actually listening to. Good question. Can it cause a tamponade? Sure, it can, depending on how much air, how much pressure, what's going on, right? Is it something to where it's frequent enough to be worried about it for us from just the air standpoint? Not really, because look at how small the amount of air is. That's not a whole lot of pressure. I'd be more worried about if this pneumothorax turns into a tension pneumothorax than I would be about the air in the mediastinum or the pericardium causing a tamponade. Fluid's going to have more pressure, so I'm more worried about that when you have like a pericarditis or a pericardial effusion, because fluid has more pressure than air does, right? Think about how much air we're under right now if you go all the way to our stratosphere, and think about how far down you can go if you were to go diving in the ocean before you start having pressure issues. So fluid causes more pressure, which is why we get more concerned about that in those effusions. This one, not so much, but it doesn't mean it can't.
And why don't we see the diaphragm sign on
Because this one is just pericardium. This is not the full mediastinum. Bingo. What do we have on that black arrow? The black arrow is pointing at what? Not the diaphragm. Fluid, right? Fluid. Got blunted costophrenetic angles. I got my pneumothorax, which comes all the way down, right? I had trauma. This is likely a hemopneumothorax. I don't know until the chest tube goes in and I see blood come out, or if I'm seeing the patient live and I know they had a trauma that's going to cause that, right? But that's another, so you can see again, look at all these different things that are wrong with a person who has a pneumopericardium. There are a lot of things that are going on because they don't just typically, they can be spontaneous, but it's rare. It's very rare for that to happen. Usually there's some kind of cause, either us in the hospital due to our procedures and techniques, or trauma most of the time. Boy, if only we could all have all pediatric x-rays, right? So this is one of your iatrogenic ones. So this is just to show you, particularly in neonates and kids, how this can happen due to complications of event. We can cause a pneumopericardium. Okay, so these are the kind of things you'll see when you're on a strict call. Hopefully not. But just to give you an idea what it looks like in peds. This is really why it's more common in peds, is because peds are little, peds are typically on event. When they're neonates, those settings are very finicky, and every kid's just a little bit different. So the RT, the respiratory therapist, got to be really careful when they're setting those, and the providers who are ordering those. Luckily, that will not be any of you. Right? Ordering the vent pressures and all that stuff, that's going to come from the pediatrician who is specialized in neonates. Right. Another picture of a pneumopericardium. Right here. And right there. Right here. And right there. Now I'm going to take a look and I'm going to say, do I see a pneumothorax? I admit the quality is kind of iffy on some of that area there. Anybody see one, potentially? I don't really see one. Doesn't mean it's not there. Again, that quality is kind of when you get to the upper part of the lungs where I'm looking. I definitely don't have any pleural effusions. I got no blunting of my costophrenetic angles right now that I can tell, so I would just call this just a straight pneumopericardium. Where's my great vessels? About right here. I got the air below. I don't have air lining the spine kind of in this area here, which is where my great vessels would sit at. Right? If there was a little line of black air kind of lining the spine area, I don't have that. So I would go pneumopericardium on this one. Nice, yeah, tracing that black line around the heart. Okay. A little bit of a different kind of review slide. What structures contain abnormal air? All right, so I heard sub-Q. Subcutaneous emphysema, perfect. What's really fun on that, you don't even need an x-ray to do that. it's painful, but if you like press on it, it's like Rice Krispies. Like when they have air in here, like if you kind of like are pressing on it, it sounds just like a bowl of Rice Krispies when you put milk in it. It's a weird descriptor, but I have no other way to describe it. Like when you first do it, you'll be like, holy cow. Don't do it a lot, it does hurt. But you don't need an x-ray to diagnose subcutaneous emphysema. But anyway, sub-Q. All right, what else we got? Pneumopericardium is what I heard. But if I have a pericardium, I want to make sure it's not a mediastinum. So what am I going to look for? There's two areas. Could maybe look up here to see. That might be kind of hard. So look at me trace my diaphragm all the way across. See that small radiolucent horizontal line right through that vertebrae. So now that I see the continuous diaphragm sign, I'm going to change from pneumopericardium to pneumomediastinum because I have that continuous diaphragm sign. Okay? That's why I say this is my favorite one. I know it's third on the list, but this is what I use first because to me it stands out the most. I'm still going to double check my great vessel area just to make sure I don't miss anything if I don't see that continuous diaphragm sign. But if I see this, I'm like, even if I don't see it on there, I got a pneumomediastinum. Okay? What's going to be hard to see on the x-ray is the initial cause of this. So this was somebody with the interstitial emphysema that then got into the mediastinum because it was right in this area, and then the pressure from that pushed it out of the mediastinum up into the subcutaneous tissue. So that's the stepwise process of that. They had some ruptured blebs, which we'll look at here in a little bit, or bully, or some alveoli that caused the pulmonary interstitial emphysema, which then went into the mediastinum, which then went into the subcutaneous tissue. All of these signs, though, for pneumomediastinum. So what does that mean? If you see subcu tissue up here, you should be looking for a pneumothorax, just to make sure. And that's going to be my secondary sign of, I see air around the pericardium. Is it a pneumomediastinum or not? I can use my continuous diaphragm sign, but even if that's not there, it's kind of hard to make out. Do I have subcutaneous emphysema? Because if I do, I'm probably having a pneumomediastinum, and I'm going to go with that because the air had to go somewhere. How did that air get there? Pericardium into the mediastinum, up into the subcutaneous tissue. It wants to escape. So if I have subcutaneous emphysema without some kind of direct trauma to that area, right? I want to make sure I'm evaluating for a pneumomediastinum. Or if I have a pneumopericardium and I have subcutaneous emphysema, pneumopericardium plus sub-QE equals pneumomediastinum on imaging. Right? You can absolutely have subcutaneous emphysema and just have the pneumothorax like we talked about yesterday. You can absolutely have that. But I want you to take the pericardium part plus the sub-Q emphysema and say if those two together, that equals pneumomediastinum. Does the pathophys of that, the process of air, does that make kind of register? Lots of clues to where even if you don't see the air in the great vessel area, you go, well, where is, because I was getting the question like, well, where is the cutoff? Is it rib 5? Is it rib 4? Like, where? It's different for every patient, right? Depending on how their anatomy sits, it's a little bit different for each patient, which is why we have these other clues like the diaphragm sign and the sub-Q emphysema to help us make that pneumomediastinum. You're like, I can make that diagnosis. You can have a pneumopericardium without a pneumomediastinum. You can't have air just in the mediastinum and not have any in the pericardium. Is that right? Because once it's in there, it's in the whole area. It's just a matter of how much are we having. So you will see this on both of those x-rays. The question is, do you need to take it that next step? So if you get a test question with this, and you get excited because you see the pneumopericardium, don't stop. There might be other things there that make that answer wrong, because it's the next step. It's a new medius dynamo. Okay. Questions on that? I know I said it like 8 times. This can get confusing, so that's why. All right. Time to go over nodules and masses. We're going to talk about some solitary nodules. We're going to talk about the carcinomas now and the metastatic neoplasms, so basically all of the cancers. When does something become a mass and is no longer a nodule? If it's less than 3 centimeters, it's a nodule. If it's greater than 3 centimeters, it's a mass. 3 centimeters. I'm not going to make you measure, but in the vignette, I might tell you that there is a 4 centimeter mass or something on the x-ray. Won't say mass, I'll just say 4 centimeters maybe if I want you to define between nodule and mass. So 3 centimeters nodule, less than, greater than mass. So somebody always asks me, what happens if it's exactly 3 centimeters? I don't know, man, I pick one. I'd probably call it a mass because we're no longer less than, so 3 and up we'll say, right? But I'm not going to give you a 3 centimeter one on the test because that would be right in the middle. What do we use to determine benign versus malignant? So size, the bigger it is, the more likely that it's malignant. The smaller it is, the more likely that it's benign. Is it calcified? What do the margins look like, right? Well-defined margins, like we talked about, more likely benign. Fuzzy, kind of spiculated, hazy margins, probably malignant. And change in size over time. That's a big piece of that as well. If it's growing slowly, it's probably a benign mass or a benign nodule. It's growing slowly. If it's growing quickly, it's probably malignant. It's probably a bad guy. Which is why one of the things we'll do when we see these patients and we get a nodule or mass or whatever it is, usually the answer is, let's redo your chest x-ray in 3 months or 6 months. The radiologist will make that determination of like how often, and you're just going to have them come in and do it. And what they're doing is they're watching for growth. And as long as it doesn't grow, they'll expand that out. They're like, okay, 3 months, do it again, 3 months, okay, now 6 months, okay, now 6 months, okay, now a year. And they'll just get serial chest x-rays over the course of a couple of years if there's something that's kind of concerning, just to watch it to make sure it doesn't like start growing quickly. So, and again, your radiologist will make that call. They'll say, do it again in this period of time for tracking of size. Okay, so we just hit all of that. The nice part about the changing in size is there's a little bit of a breakdown there for you, just so you have that for your clinic, right? Mid-range is vague, which means it can't be specifically tested on, but knowing that if it's growing quickly, like within weeks, it's probably just an inflammatory process. Even cancers don't grow that fast, right? So if you get an x-ray and there's something on there, and then say you have them come back for a week or 10-day follow-up or 2-week follow-up or whatever, and you get it again, and all of a sudden that mass has grown in that short period of time, it's an inflammatory process. Cancers don't grow that fast. Okay, but your mid-range coming back in a couple of months and it kind of gets like a centimeter bigger or a centimeter and a half bigger or something like that, that's when we start getting concerned. And then your benign ones, pretty much, it takes like 2 years to notice a size difference. They grow very, very slowly. Here, for the follow-up, so I said the numbers are FYI, because your radiologist is going to tell you in the report. You don't need to memorize any of this kind of stuff here, right? Because you notice how like nodules, less than 3 centimeters, okay, cool. But I broke down the numbers even more of like, well, how many millimeters is it? What's the follow-up? For my exam, you don't need to memorize that. The radiologist will help you, but it gives you an idea of how soon we do some of these things and when do we jump to a high-res CT, that kind of thing. Your low-risk patients and your high-risk patients is the key aspect of this slide. This is what I need you to know. I need you to know the low-risk patients and the high-risk patients. It's fairly straightforward. Low risk is young people with almost no smoking history, well-demarcated margins, and area anywhere other than the upper lobe. Your high risk is your older people, your heavy smoker, in the upper lobes, or has irregular margins. All the things that would make you go, you're probably at a higher risk for cancer anyways, because you're older, you're a smoker, I don't have clear margins, right? And as you see here, there's a good portion of our bronchogenic carcinomas that sit in the upper lobe, because where our bronchi, they're sitting right in here. So that's why upper lobe becomes a higher risk if we see those nodules or masses in that area. So that's the area that I need you to worry about. I don't need you to spend brain power memorizing all of those frequencies based off of the nodule size. Why should you care? Because I said so. No. Bronchogenic carcinoma is the most common fatal malignancy in men, second most in females. Okay. Not the most common cause of death, the most common fatal malignancy. So what does that mean? Most common fatal cancer, basically. What are your three key symptoms? Hemoptysis, so coughing up blood, unexplained weight loss, and hoarseness. I say with or without sore throat. A lot of times there is no sore throat. Why? It's infringing on the vocal cords. That's what's causing the hoarseness. So the throat, the back of the throat, it's not sore. It's not bothering them. So all of a sudden they start getting more hoarse. Maybe they're coughing up blood every now and then. You have to actually ask that question too, because they won't even realize it. A lot of times, like, actually, I did see some small red streaks or brownish streaks in my mucus, last week, but kind of describe it for them. Unexplained weight loss. The more of these symptoms you have, the more of a chance that this is a cancer. We are going to go over the squamous cell, the adenocarcinoma, the small cell, and the large cell. You are going to be able to tell, hopefully, by the end of this lecture, or at least by the end of studying it before the exam, based off of patient presentation and appearance/location of the mass, what is my most likely bronchogenic carcinoma type? This is good news for you, because then you can tell the patient what's going on, get them follow up, figure out, yes, you're going to get a biopsy to confirm it. 100%, you're going to get a biopsy to confirm it. But you will have a chance to make a really good, educated, most likely guess off of these things by the time we get down to the end of this section and you study it for that Thursday. Maybe not by the end of the lecture, but when you go back to it. Okay? So can you end up having other things that are causing because of bronchial obstruction, because of the tumors? Yes, you can get a pneumonitis, you can get an atelectasis, you can have an effusion and we don't know why, right? And that's why you go back to those pleural effusion slides. Malignancy and cancer is on there because that can cause that. So, but more importantly, let's figure out where these things are and what's going on. Squamous cell. Okay? Squamous cell, central in location, central of the chest. They are coming from the lobar and segmental bronchi. So right here at the end here, okay? They can likely lead to an atelectasis, right here. Here's my atelectasis. Down, leading right into my malignancy. These things grow quickly. These are rapid growers. So, if I have a patient who is having hemoptysis, right? Maybe not all three symptoms, let's say hemoptysis, and maybe some weight loss, or even just the hemoptysis, right? And I give you this x-ray. We talked about atelectasis, I don't know how to say that plural. Those don't cause hemoptysis, right? So this patient's probably going to have hemoptysis, shortness of breath, maybe a little bit of chest pain. You get this x-ray, they're probably a smoker, right? Maybe older, maybe not, but definitely going to be a smoker. And you get this x-ray, and then the question is something along the lines of, what is the most concerning abnormality on this x-ray, right? So I give you, say, the 4 different types of carcinoma and atelectasis, because atelectasis is here, but definitely not more concerning than the cancer that they have. Right? Just a way for you to kind of piece that out and what some of those more kind of harder, kind of distractor type questions might look like. Okay, still haven't created you guys. Just been teaching it long enough to know some of the things that sometimes come up on there. Okay, we get a CT, right? Concerned. CT shows, look at the calcifications in the CT now in my mass. See all those little kind of whiter, brighter kind of little dots inside that mass? Those are the calcifications of your malignant tumor. So what's going to happen in real life is basically got the x-ray, concerned, ordered the CT to help confirm that that's what's going on in there, because I can really get that fine detail. Look, I can even see the spiculated margins kind of here on the CT, like it's all kind of funky and kind of pointing out. All right, and I got the calcifications in there. And then biopsy versus PET scan, you know, is the next one, because if I have lung cancer, I need to make sure I don't have cancer somewhere else. But really what's probably going to happen is you guys are never going to order the PET scan on this patient. You're going to see the chest x-ray, you're probably going to confirm it with a CT, and then they're going to oncology. Oncology will eventually order the PET scan for you, but you're going to order a biopsy and oncology referral. You'll learn that a little more in home and hemo, kind of how to take that process. But just kind of giving you a little bit of background on how the clinic's going to go. Okay. Adenocarcinoma. Solitary lesion. Doesn't always have to be this small. Can be bigger. Solitary lesion, usually peripheral in location. Okay. Very slow growing. A little bit of a thick wall that kind of stands out in that peripheral location. May or may not have the hemoptysis. Why? Look at where it's at. It's not on my main bronchi. This may not be causing any symptoms at all. Okay? But how many radiopaque circular round nodules in the peripheral locations of the lungs have we talked about so far? Like none. Someone say 250. Yeah. So TB, but TB is cavitary, right? A little bit bigger in cavitary. When we saw that cavitary pneumonia, that's a good point. So TB is a possibility, right? Absolutely is. Not necessarily really cavitary on this guy. A little bit more solid. Maybe you will see a little bit of cavities in there. But what's TB definitely going to come with? TB is going to come with some of those infection type symptoms. This guy, a lot of the times, or gal, is probably asymptomatic, especially this early on. Or if I wanted you to distinguish between this and tuberculosis, maybe give you some endemic stuff, maybe give you some travel history, some immunological history, something to make you think that this is unlikely TB. So, or it'll be a picture with a lesion that's bigger than this, so it stands out a little bit more that it's not cavitary. So, but that's good. I like that you're thinking that, because now you got to figure out how do I distinguish between those things. This patient's probably still going to be a smoker. Right? Almost all of these things, smoking makes you more high risk for all of these cancers. Although it's slow growing, still not necessarily benign, right? It's still a lung cancer. It's just not as life-threatening or as quickly as, say, the squamous cell one here that we just looked at, right? So you have different varying pucker factors, as I like to call them, when you see these things for your patients. This is less of a pucker factor than your squamous cell. Okay. Another one, kind of fuzzy, right? Recognize it's not necessarily super peripheral, like we talked about, but it's also not connected to the center area, and even on the CT, you can kind of see I got like this nice little bit of lung tissue kind of completely surrounding it. So I'm not connected to that central mass. That's really what peripheral means. It means not connected to the central structures. And again, your stepwise process. X-ray, okay, what's going on? CT, verify it. Yes, the next imaging is PET scan, but you guys aren't going to order that. Now the one that I hope you never have to tell a patient they have. Okay. Small cell also includes the oat cell carcinoma, primarily central in location. And you're like, well, crud, the squamous cell was central in location. How do I tell the difference? Look at my symptoms. Small cell carcinoma, specifically the oat cell, secretes an antidiuretic hormone. It mimics patients that have Cushing's or what's called SIADH, syndrome of inappropriate antidiuretic hormone release, right? So why is this important? Well, first of all, your symptoms are right down here. Difficulty in walking and swallowing, loss of muscle tone, slurred speech, vision problems, sleep disturbances, right? There's a lot of symptoms I can pull out of here and give it to you in a vignette with my x-ray to help lead you towards small cell as opposed to squamous cell. I didn't give you any of those for squamous cell. I said hemoptysis, possible weight loss, your main cancer ones. I didn't give you any of these guys down here. There's a reason for that. Part of that reason is that you haven't learned SIADH yet as a disease process. You will in endo. You haven't learned Cushing's yet. You will in endo. So to just present you a Cushing's patient would be too high of a level right now because you haven't absorbed that material. So I'm going to break it down and give you the symptoms if I want you to think this was a central mass. I'll also put a small plug in for future you in the clinic. If you newly diagnose a patient with Cushing's or SIADH because of the symptoms and the lab results, which is what you need a lot of the times to diagnose endocrinological disorders. If you make that diagnosis new, even though there may not be complaining of pulmonary or chest symptoms, you need to order the x-ray. Because you can misdiagnose a patient by diagnosing them with SIADH or Cushing's because of the labs and the symptoms and everything fits, when in reality, it just looks like that because they have a small cell or oat cell carcinoma. So you start fixing the disease problem, but the problem is actually the cancer. So if you're a new diagnosis on one of those patients, order a chest x-ray just to make sure you're not missing it. I don't know if they'll harp on that in endo or not, because they're focused on teaching you about those disorders and like how to find them and how to treat them and how to diagnose them. But make sure you order a chest x-ray on these guys. Looks just like the squamous cell. Okay? Bigger, a little bit more gnarly on the CT, but as far as location goes, pretty darn close. I will say the one difference to a trained eye when you guys look at these more is notice how this one creeps all the way up into the apices, right up in here. Let me go back to my squamous cell. Not really. I have clear apices. I have mostly just an atelectasis, but the mass is a little bit lower on my squamous cell because it's sitting on the lobar area, right? It's sitting on the bronchi. But when I go to my small cell, I'm all the way up in here. This is the one too, that's why you're getting that hoarseness. It's infringing and pressing up on those vocal cords. So look at the hoarseness on this one. Going back to the symptoms, the slurred speech, pressing on that laryngeal nerve sometimes. Okay? Vertigo, dizziness, all of these symptoms. If I want you to pick this one with the x-ray, I will have probably a minimum of 3 of those symptoms in the vignette. Okay. Same concept. Pucker factor. Again, a little bit lower, right? Not all the way up here. But symptoms are what's going to tell you. It's central in location. It's centralized. It's connected. I don't have lung tissue in between it. I have all those symptoms. I'm thinking small cell. I order a CT, eventually PET scan. Same stepwise process. For you guys, CT is your definitive study because that's what's going to find it. Biopsy, send to oncology. Last but not least, large cell. It's large. Even on this one though, right, it says peripheral in location. Notice I have a small, albeit small, it's there, barrier of lung tissue between the mass and the central structures. That makes this peripheral. Now, well, how do we get these things confused? There's no size. It just says, oh, larger peripheral regions. Great. The difference between this one and adenocarcinoma grows rapidly versus grows slowly. So what happens? We see an adenocarcinoma, and we're going to repeat X-ray in, say, 3 months, or maybe even 6 to 8 weeks, whatever the radiologist says based off of the size. They come back, and it's almost double in size. This is just me anecdotally, right? Okay, large cell. And that grew really rapidly. Whereas that adenocarcinoma is going to look exactly the same over a couple of those follow-ups because it grows really slowly. Okay. So how do I know it's large cell? Well, it's not any of the other ones. How do I know it's not any of the other ones? Because when I give you the descriptions in the vignette, none of those match up with any of the other ones. Because the central ones either had the SIADH thing, or they were centralized, and here I have that nice lung tissue line separating the two. And then adenoma versus large cell, it's not necessarily a size, because I don't have a size cutoff, it's a speed of growth. Those are your distinguishing factors between the two. Same, CT, PET scan, all of that. So, now that we're all experts, here's a question. Similar to something along the lines that could be on the test. Not exactly, but similar. Give you an idea of what some of these things look like. 68-year-old smoker, history of a mass on X-ray that I was scared to follow up on. They saw somebody else. They didn't see you originally, right? They PCS'd in, something along those lines. You went to the chest X-ray to follow up, and you compare it to the prior one, and you see very little growth. You see very little growth. You also see the location that I have given it to you. So what's your most likely diagnosis? Adenocarcinoma. Got it. And yes, parabronchial cupping. Yes, cephalization. Yes, pneumomediastinum. Sorry, pericardium, not mediastinum. I apologize. I can't see up here now. No, I don't think I see a pneumothorax. So again, just showing you, right? None of that matters on this one because I'm asking you what the most likely diagnosis is based off of the vignette, right? So none of those other things matter on this question, but if you were to just sit down and read through all this before reading the question, you're going to waste a lot of time on the exam. It's good because you know how to do it, and it's going to be helpful for you in your clinic, but you only have 75 minutes to get through 50 questions, so. And then when you get to phase 2, you'll have 75 minutes to get through 60 questions. And then when you take your pants, you have a minute per question. 360 minutes for 360 questions. So use your time wisely. And then you do your research, you get 5 minutes per question. It's great. Because they let you look stuff up on your research. Yeah. It's new. They just started this like 2 or 3 years, like 3 years ago, allowing us to look it up on our research. All right. Well, because they determined that in real medicine, you don't know everything and you constantly look stuff up. So like, we're going to give you time to look it up. You can't just like not know it. You have to be able to like nail it down to 2, but then we'll give you time to verify which one it is. And so that's the research. But that's 10 years down the road, 12 years down the road for you guys. Okay. 68-year-old male with a history of smoking found to have a solitary lung lesion that is 9 millimeters in diameter, globulated, trying to put those words together, on CT, and has appeared since his last chest x-ray 9 months ago. The patient wants to know, what are the chances that this is bad cancer? Bad cancer? Or nah, don't worry about it. What do you guys think? Yeah, this is bad cancer, right? What are the things that tell you? So the things that tell you on it, first of all, I went from nothing to a 9 millimeter mass in 9 months. That's a concern, okay? I have solitary lung lesion. He's a history of a smoker. He's older. Okay? Those are all things to be concerned about that. I can't give you a test question like that. I just want you thinking high risk versus low risk. So now I have a 76-year-old smoker with hemoptysis and shortness of breath that's been ongoing for the past few weeks. You order a chest x-ray, you notice, look what I told you, you notice you have the upper lower lobe atelectasis. On the exam, I might not tell you that. I might just leave it there for you to find. What's the most likely diagnosis? Now, I couldn't say most likely diagnosis on a test and give you atelectasis and what? Squamous cell, right? I couldn't give you most likely unless I told you there was atelectasis there, because then that's obviously not the answer. But if I wanted to put atelectasis or squamous cell in the thing, I would have to say, what is the most concerning diagnosis? Right? Something along those lines. Good. 72-year-old male with overall muscle weakness. Notes difficulty swallowing. 70-pack year history. Hypertension, diabetes. Oh my goodness, he recently was diagnosed with SIADH syndrome. Here's my x-ray. What am I worried about? Small cell. All right. And then here's another question to kind of belabor the fact that you guys already know this is large cell. Right? Gives you some examples of what some of these things might look like. Take a 10-minute break, come back at 2 after. Thromboembolic disease. Big fancy words for blood clots. Okay? Thromboembolic disease. I care about this in what area of the body? The chest. Because that's the lectures we're in, and that's the block we're doing. So, usually older people, after 60 years old, do not let age be your disqualifying factor. Please do not read a vignette and see that they're 55 or see that they're 35 and rule out the fact that they can have a thromboembolic disease, because they can. All right? Most common cause, calf, deep vein thrombosis, primarily usually in the calf. So what ends up happening is they get a blood clot in their calf for a multitude of reasons, primarily immobilization or surgery. Immobilization can look in many forms, i.e. somebody who's bedridden, somebody who sits in a wheelchair, somebody who's a smoker and takes really long flights from overseas and back. So you're military people, right? Because you're immobilized. So when you walk around, if you remember a little bit of A&P, if they talked about it, you walk around, your calf muscle squeezes, it squeezes those veins, it helps push blood back up and return. If you have other conditions that can make you more at risk for blood clots, like smoking, over 35 women on birth control, all those things that make you at risk for blood clots, and you immobilize the calves for a long period of time, like 12-hour car rides, 12-hour flights, things along those lines, it puts you at risk of developing a clot in one of those deep veins in your calf. Okay? No big deal down there. It's a vein. It's not my arteries. It doesn't really affect me very much. But then what can happen is through compression or pressure or just it building up, a piece of that clot can break off from that deep vein, travel through the venous system into the right side of the heart, go into the right side of the heart. When I go into the right side of the heart, where do I head out now? I head out to the lungs via what? The pulmonary artery. That's where the clot latches on. Once you have a clot, more blood cells and platelets attach to that clot, causing what we were concerned about, which is a pulmonary embolism. So the pulmonary emboli do not originate within the pulmonary artery. That's where they settle, most oftenly from a clot from the deep veins of your lower legs in your calf region. So there's your pathophys of how these pulmonary emboli happen, and that is why these things happen so suddenly. Is because there's not really, there's some high risk stuff, but patients aren't noticing any symptoms until the clot hits, and then it starts building even more, and they end up having that pulmonary embolism. It's very rare to catch symptoms like that beforehand, so this is a very quick thing that can happen. So understanding the risk factors is important. Here they all are. Everything I just said. Mobilization. surgery, right? Why surgery? Well, by surgery, I'm naturally activating the body's clotting factors, and usually after surgery, you're immobilized for a while, depending on what surgery you're having. So you're just lying in bed. So that is an increased risk factor. Smoking, pregnancy, oral contraceptives, cancer, familial disorders, all these big things, right? So understand your risk factors, and we're going to have, you guys probably hate this by now, but we're going to have a nice, lovely chart and a flow chart. It's going to be a little bit more clear than the one from the last block. That was the feedback I got on that flow chart for the FAST exam, but this one's going to be nice and tell you what do I order and when do I order it and what's going on. Because if there are no contraindications, your CTPA, or CT with contrast, however you want to do it, CTPA, pulmonary angiography, is your study of choice. But if you can't give contrast for any reason whatsoever, they're pregnant, they have poor kidney function, right? Those are the two main ones we talked about. They're allergic to the contrast. Then you go to your VQ scan, your ventilation perfusion. So CTPA is your study of choice to evaluate for a pulmonary embolism. If they can't have the contrast for any reason whatsoever, you get the VQ scan because it doesn't have contrast involved. So allergic, kidneys, pregnancy. We'll talk about pregnancy and stuff too when you would do an ultrasound instead. We're going to have that in the flow chart. But don't get excited when you see the CTPA unless you go back into the vignette and ensure that they don't have something that contraindicates that contrast. You get excited because you know it, you'll click it, and then you'll miss the part that they're pregnant, or they have poor kidney function, or they have stage 3 kidney disease, or whatever the case may be. Okay, chest X-ray is still going to be an initial study. Why? Because what if it's not a PE and it's something else? I will tell you that there are a couple of things we're going to talk about that in the textbook say if you see this, you think PE on a chest X-ray. Clinically, I've seen multiple PEs in my life. I've never seen these X-ray findings. But it's in the book, so I gotta tell you about it because it could be a pants question of what X-ray finding would lead you to suspect the pulmonary embolism in a patient. So you gotta know what it is. If you suspect PE, you're gonna get the X-ray, but then you're gonna jump to whatever is the most appropriate definitive study or confirmatory study, right? Get the X-ray, but then move on. The X-ray is there in case there is no PE. You can go, well, what the heck else is going on? Okay, let me look at the rest of it, find pneumothorax, find a pneumonia, find whatever. That's why we get the X-ray. We'll talk about the ultrasound studies as if concomitant leg pain and chest symptoms you can get an ultrasound. We'll talk about that in the flow chart. Don't get hung up on that right now. It'll be very kind of delineated out based off of what type of patient you have and what you're supposed to do. Right here. So, non-pregnant patients. This is for non-pregnant patients. Okay? Don't worry about the Wells score criteria. I'm not going to test you on Wells score. Cardiology will help you on Wells score. EMED will help you on Wells score. What Wells score ends up being is this nice little kind of math equation where with certain symptoms, certain ages, the patient gets a certain number of points. And based off of the point system, you can have a suspicion of likelihood of PE. But that's more diagnostic. That's going to be other courses. What I need you to know is the big red circles. If I have a non-pregnant patient, can I do a CTPA, CT pulmonary angiography? If the answer is yes, because they can handle the contrast, that's what they get. If the answer is no, because they can't have the contrast, I'm getting my ventilation perfusion or my VQ scan. Non-pregnant patients, that's the algorithm. For non-pregnant patients with suspicion of PE. Can they have contrast, can they not? That tells you what to order. Start always with the CTPA unless they can't have the contrast. Okay. What if they're pregnant? Because now I'm not just thinking about contrast, I'm thinking about radiation. A VQ scan is radiation, right? So I need to really be cautious about some of that stuff. So now my question becomes, and this is the one where people get tripped up, so this is the one I would recommend you really understand and know, is if the patient's pregnant and I think they have a PE, my first question is, do they have leg pain? Do they have leg pain? If they have leg pain, CUS is ultrasound. I get the ultrasound. If they have leg pain, I'm going to do an ultrasound. Because when I do that duplex ultrasound and I see that blood clot, I'm done, I treat. I'm finished, we found it, I treat them. Okay? If they don't have leg pain, or if the ultrasound is negative, I get the chest x-ray, right? Why do I get the chest x-ray? Because that's my initial study, they're pregnant, it's very low amount of radiation, okay? So, ultrasound first. If they have symptoms, if they don't have leg symptoms, chest x-ray first. All right? If they have leg symptoms and we do the ultrasound and the result of the ultrasound was negative, chest x-ray. Based off of the results of my chest x-ray, I go to my other scans. If by some off chance you notice what we're going to talk about, the findings on the chest x-ray that are indicative of a PE, right? One of them is called a Hampton's hump. We're going to go over those. I'm not going to make you pull those out on image because they're so rare to see, but it will be in the vignette if I want you to know that. Your chest x-ray showed a Hampton's hump, or your chest x-ray was normal or unremarkable, right? So if I'm going down here on the algorithm, and I've already gotten to the point where I'm like, hey, pregnant patient, no leg symptoms, I'll say chest x-ray shows this, if I want you to decide between these two things. I'm not going to make you find me PE abnormalities on an image, okay? But if the chest x-ray is abnormal, now I have a very high suspicion for a pulmonary embolism, and that suspicion is so high, and my ultrasound I already tried, either they didn't have leg symptoms or my ultrasound was already negative, I'm giving the contrast and I'm giving the radiation. Because if mom dies, guess who else dies? Baby dies, right? So if we don't save mom, we can't save baby. So if it's that to the point to where I see those abnormalities, we got enough from a risk factor to say, we're giving the contrast, we're giving the radiation because we need to verify how bad is it, where is it, and do they need surgery, right? Do they need to go to cardiovascular surgery? If the chest x-ray is normal, in which many cases it will be, we do the VQ scan. Because I still don't have enough. I suspect PE, and either don't have leg pain or I did and my ultrasound was negative. My chest x-ray is normal. I still kind of think it could be, but I don't have a smoking gun to risk the contrast and the amount of radiation that a CT actually is. So we're going to do a little bit of radiation with the radionuclide and do my VQ scan. As far as the treatment stuff goes, you guys can save that for home, cardio, all that stuff. I need you to know, based off of the algorithm and the information I give you and how the patient presents, what do you order? Because when it comes to pulmonary emboli, time is life. Ordering the wrong study can delay that patient care and be the difference between saving that patient and not saving that patient. You can do everything right, and it still won't matter sometimes. This is one of those things. Saw this when I was a rad tech. We had one of our surgeons who actually had a surgery on himself, was sitting at home, and I was working in the ER. I was on shift that night, was sitting at home, and he called into the ER. He knew the doc, obviously, because he was one of the docs in the clinic over at Travis. And he was like, hey, got some leg pain, and it's a little bit red, so my wife's driving me in. We just want to make sure it's not anything crazy, it's not a DVT or anything. So we're on our way, and if you just want to kind of get to bed ready. I'm like, cool. They're like, yeah, Dr. Smith is coming in, you know, and he'll be here in a little bit. So we're like, cool. So we get everything ready. They call an x-ray over, like, get ready for the chest x-ray because we're going to get that regardless just to make sure nothing's going on there. And I still remember he rolls into the ambo bay. His wife drove him, but they got him in a wheelchair, and his wife's wheeling him around, and he's talking to us like, hey guys, I know this is probably nothing. You know, I just really wanted to be just like that. CPR for about 20, 25 minutes by a whole team of people, including myself. Did not bring him back. He had a DVT. It broke off on the way to the hospital, hit the pulmonary artery, and completely blocked it off. That's how quick this can go. That's why this is super important. Nothing was done wrong. We even had a physician who knew what was going on, knew what the concern was, came in a timely fashion, and sometimes it still doesn't matter. But if you can make a difference, this is where you can. The non-pregnant is super simple. Can you have contrast, can you not? This one gets a little fuzzy. If you have questions about it, let me know. Because you will probably at some point in your career have a pregnant woman where you're concerned that there might be a PE and you might have to run through this algorithm. Well, again, if she's allergic to contrast, then problem solved. When you get down here, though, contrast allergy doesn't, that's a good point, I'm glad you said it, right? What if she's allergic to contrast? That only matters down here when I'm deciding between CTPA and VQ. That contrast allergy matters not in the rest of that algorithm before we get to that staging point. Okay, so here are your uncommon radiological findings. I'm not going to make you pull them out on x-ray for this course. Be aware of them. They can be test questions on your pants. Primarily the two that I care about the most, your Westermarck sign and your Hampton's hump. Those are your pathogenomic terms that the pants might throw at you and might throw on there. Or if you got that ER preceptor who wants to like puff out their chest a little bit, you're like, let's see if they really know this thing that never gets seen. Like, oh, what are you looking for a chest x-ray for a PE? Those are your money words right there. Because a lot of these other things, the unilateral pleural effusion, the elevated hemidiaphragm, these are pretty non-specific. Enlarged pulmonary arteries or vasculature, we've looked at that for multiple other things, right? I'm not going to be overly concerned. I'm not going to use that to go PE, not PE, when I'm talking about chest x-ray. Now, that can be abnormalities potentially in your report, sure, which then brings you back to this chart of abnormal, do a CTPA, right? As long as it's not a normal chest x-ray. But I told you, I will tell you what the chest x-ray results are if I want you to be at that point in the algorithm. All right. Here's your Westermarck sign. Right?
Okay.
Right? You guys all see it, right? I'll point it out to you so you understand, but then again, it's hard to see, and especially in a situation of trauma, you know, it's just difficult. So what your Westermarck sign is basically saying that there's decreased blood flow in your vasculature, some of the smaller vasculature, therefore from pulmonary emboli, not the ones in the main pulmonary artery, because they could be in the smaller vessels as well, causing a lack of blood flow to an area of the lung. Which is why when you compare your normal to your abnormal, you see a significant decrease in your lung markings or your vasculature, because there's no blood flowing through those. So it's darker. More air, less fluid. But look, 2% of patients. If we use this to determine things for PEs, we would lose 98% of our PE patients. Only 2% this shows up on, and it depends on what stage the disease is in and how many of those vessels are blocked up. All right? If I have a main PE sitting just in my main pulmonary artery, I'm probably not getting a Westermarck sign because it hasn't gotten into those smaller vessels yet. But that's the definition of it, a more radiolucent area of the lungs with a decreased amount of lung markings compared to the rest of it because of the lack of blood flow from the clots in those smaller vasculature vessels. Hampton's hump. There's a little triangle right there. A little triangle right there. Right? Little wedge-shaped opacity in the peripheral lung, bases against the pleural surface. It's representing some hemorrhage and necrotic lung tissue. Again, if I have hemorrhage and necrotic lung tissue, this probably wasn't an acute PE. If I already have necrotic tissue to the point to where I'm starting to show up on radiologic images, they probably have a small peripheral pulmonary embolism sitting down in here. It's not centralized. It wasn't causing a whole lot of symptoms until it got to the point now where they're just like, I keep being short of breath and like activity. Like, I'm just coming in. You get the X-ray just to see the X-ray, and you got this thing here, and you're like, okay, well maybe you have a PE there. Yeah, there, yeah, good job on the cardiomegaly. Yeah, right. Super minimal, right? Don't expect you guys to pull it out for my exam. Know what they are, know their definitions, so if given to you in a vignette, you understand what that means. And your ER preceptors. Now, the good news to knowing this, when your ER preceptor wants to puff their chest out and ask you that question, great, you're gonna get a high five for knowing it. It just means harder questions are coming. So like, play that game with how you want, right? You can kind of play a little dumb and then be like, no, tell me about this Westermark sign. I haven't heard of that before. And that'll fill time, or you can impress them, and then just the same thing with surgery. The questions just constantly get harder until you get one wrong. They take pride in that. I don't know why, but they'll start asking to name vessels that like you didn't even learn. Because as a family practice PA, we don't really care, but as a surgeon they do, and they'll keep going until you get something wrong. So play that with a grain of salt. That's in 8 months, I know. Now let's look at the imaging. That's what this is, an imaging course. Now you've learned, or you know, or you will know by two weeks from now, when you're concerned about a PE. So now when we order the CTPA, or the CT with contrast, right, either one of those are acceptable answers. Because if I put CT pulmonary angiography, it kind of gives it away. So CT with contrast is the same thing as a CTPA, right? Because I need contrast, otherwise I can't find this clot. Big red arrows. Right there. This is early enough to where it's concerning, but it's not to the point, right, that they're going to die within the next couple of minutes. But this would be potentially the start of what we call the widowmaker, because it's in both branches of the pulmonary artery, and it crosses over what we call the saddle. So this is concerning for sure. We also have an extra one right here. Anything that is gray, that looks like it's called a filling defect, is what we call it, throughout the vessels, is going to be a blood clot when you do these CTs with contrast and you're focusing on the arteries. Right? Here's my main ascending aorta, descending aorta. Okay? But this is my pulmonary artery. And remember, if this wasn't a PE study, I could also use this to diagnose what? This image. If it was there, it's not there. Think way back.
Enlargement stenosis.
So, the pulmonary arterial hypertension. Remember, if this pulmonary artery is wider than the aorta, can be from the stenosis, like you were getting there in that aspect. But the pulmonary arterial hypertension, this image is enough to diagnose that if I wanted to, or really just rule it out. That pulmonary artery is not clearly wider than my aorta. So they don't have that, but they do have this PE right here. And it's not just here. When you get the images, scroll all the way through the lungs, because like trace all these little vessels down, right? Because this vessel here, you trace that down, you can end up with one of those peripheral clots as well. So you'll have to treat it. It's not as life-threatening as the one in the main artery, but it still would need to be treated with like blood thinners, anticoagulants, things like that. Yeah.
These patients, they have to go to surgery, right?
Usually, yeah. Yeah.
You start them on analytics right away, and then they go to surgery.
So yes, depending on time frame and things, like I'll save that for cardio and pole, because there are different thrombolytics, there are different things you can give, whether it's an MI, because it's a similar concept, just not in the pulmonary artery, right? It's just in the cardiac arteries. So depending on timing and what's going on, there will be treatments, but it will be over there. Here's your VQ scan if they can't have contrast. Also known as a ventilation perfusion scan, right? And I even have it here on the side for pregnant patients. If the chest x-ray is normal, VQ scan. If the chest x-ray is abnormal, then they can have the contrast, CTPA or CT with contrast. What the concept on the normal scan is we've given the radioisotope, it's checking the blood flow, it's a ventilation perfusion scan. So it's watching to see how much of the lung tissue is being perfused with the blood, okay? So my normal, I should see full, beautiful shaped lungs because I want all of the lung tissue to be getting perfused with oxygenated blood. And so if I see that minus my heart shadow, that's a heart shadow, right? That's a normal scan. When I see gaps in my picture, those are areas of lung tissue that are not getting oxygenated blood. So then I can say, hey, I have multiple PEs on this patient and they need further care. So it's the gaps on this one. A lot of the things we looked at with like nude med scans or PET scans, where I'm like, what's highlighted like a Christmas tree? In this one, it's the opposite. Where are my gaps? Gaps are abnormalities because they're not getting that blood flow. Look, it's my chart again. Okay, enough said. Here's what that ultrasound looks like. Okay, just so that way it's not the first time you've ever seen it. So the first image is what the vessel looks like on its own, just getting the scan. Okay, no compression. Next, what they do when they're doing the ultrasound and they're doing it, they then keep it there and they put pressure on it. Because if it's a vein with no clot, because remember, fluid is black on ultrasound. But I can't tell you blood, like a clot, and blood that's liquid, that's the same density as far as the ultrasound is concerned. So I don't know if that's all just liquid blood or if there's clot there. So they compress the vein, and if there's no clot, the whole thing should collapse. Because it's a vein. It should just collapse. This is incomplete collapse. This is clot. This is clot in the deep vein. It is not fully collapsed. Yeah?
How much concern do you have for dislodging it?
Yeah, good question. How much concern do you have for dislodging? Not as much as I have if I don't find this and misdiagnose it. Is that a possible risk? It is. But it's not as great of the risk of not realizing they have this. Because if they had it, guess what I'm doing now? I'm treating. I'm treating. And you're going to learn what that treating is. It's going to be with anticoagulants, and you're going to treat. You're done. You don't have to give radiation. You don't have to give contrast. You've just diagnosed, and now you're treating them. Yeah.
I was curious, so for this procedure, like, are you just running it down there like that?
So a lot of times the ultrasound tech will do this one, right? It's a specialized type test. Maybe if you guys get really adept at using the ultrasound, you might be able to, but a lot of times this is ordered by the ultrasound tech, okay? And so they know where the main veins are going to be in the calf, and so they're kind of, they're just kind of scanning and compress, and they'll go down a little bit and compress, and go down a little bit and compress, right? But again, when am I doing this? I'm doing this in my pregnant patients. When what? When they have leg pain. Man, where does it hurt? One finger. Can you point to me where it hurts? Oh, right here. Great, that's where I'm starting. Right? So that's kind of what you would do if you were actually doing it in clinic. Okay, questions on that? All right. Let's step out of that. Let's go back. There's a lot of abnormalities on here. What's this one called? Subcutaneous emphysema. Right? Probably from what? Pneumomediastinum. How do I know that? Look at my continuous diaphragm sign. Right there. Good stuff. No patient vignette, but what do we suspect? Based on what we've seen in class. Squamous cell. Good. Here would be what the vignette would look like. 45-year-old does urgent care, cough, pleuritic chest pain, several weeks. X-ray notes a central lesion with segmental atelectasis. Finding consistent with which type? I could give you the photo, I may not give you the photo. It just depends. But the only one we talked about that segmental atelectasis in was the squamous cell. Can it happen with the other ones? Yes, but I gotta try to differentiate it a little bit for you guys to help you distinguish between the two with the soft ones, right? All right, so we got a 72-year-old male, ED, 2 weeks after left hip fracture that requires surgical fixation. He returns due to new shortness of breath, pleuritic chest pain, elevated right hemidiaphragm and infiltrates, which is an abnormal chest x-ray. I really don't care too much because he's a 72-year-old male. What 2 studies could you get that would verify your diagnosis? CTPA or CT contrast or VQ scan. And you're going to decide that on this patient based off of can they have the contrast. What do we think? Adenocarcinoma. Questions on that? Okay. It was a little bit thicker too, covers a lot of important topics, different things, right? The PE stuff, know that chart, guys. Really know that chart. Let me just switch lectures here real quick. We'll keep going. Where did I put the flag? I thought I put it on my head. Oh, it's right here. Okay. I kept this in here. This is not my slide, right? This was the previous instructor's slide. This is from one of his deployments. I just really like, I've been on deployment before too, but I have a picture like this. The fact that for those of you, I know some of you have deployed, some of you probably have not. But when you deploy as a medic and in a setting, this here, when people are kind of wheeling them in and kind of seeing that, it's impactful, right? They're scared, they're hurt, they're injured, and then they have no idea where they're going and what's going on. They see the American flag, and you're like, they feel like they're in a safe place. You can see it. The best story I have to something like that too is I can't remember a while back, they had that Operation Allies Welcome where they brought all the refugees over. I don't know if I told you this story or not. I was there for that as part of at Holloman as one of the safe haven teams. So I did multiple jobs. One of the things I did was I was the response team when the planes landed on the tarmac. So kind of exciting actually. We gave two berths on the tarmac. We had multiple people syncopized on landing. So like we were the response team as part of that. So it's kind of cool. Who never thought I would deliver a baby on a plane in the tarmac? Never thought I would do that as a PA, but I did. Anyways, one of the things, anybody ever been to Holloman? Know where it's at? Right? Right outside Alamogordo, New Mexico. So imagine everything that happened in Afghanistan, all these refugees leaving Afghanistan, being told you're going to America, we're going to indoctrinate you into America. You have this long stop in Germany, all these long flights. You don't know the language, you don't know anything. You finally land, and you walk out the plane, and you're looking at Alamogordo, New Mexico. In the summertime, so it's still 110 degrees like it is in Afghanistan, and the topographic map is exactly the same. Some of the faces they had, they thought they were getting punked. And they thought we would turn them around and sent them right back until they saw the flags on their shoulders, and they would take that same deep breath that a lot of them did when they realized that it said United States and had the flag. They lived like you should have seen some of their faces. But it goes into like why we do this. I was out there for 3 months, right? We had one radiologist, and as part of immigration, we have to make sure these all guys don't have what? TB. I have one radiologist. We're running 24/7 ops. They can't work 24/7, 365. So guess who read all the chest x-rays looking for TB? This guy. Now, when he came in, he would overread them and make sure I didn't miss anything. But from an initial, like, you need to be isolated versus you can go back into Gen Pop, that was on me. So that could be any of you in this room for any type of mission or anything like that. So that's why I kind of harp on some of this stuff and why it's important. But we'll bring it back home for some of the things that we'll do. And that includes the Guard and Reserve in here because you guys will probably deploy before a lot of the active duty do, depending on what's going on. Reserve really Guard. Or Guard and then Reserve. Reserve is the state, right? That's the federal, the Guard is the state. See, I've been active duty my whole career. I'm sorry, I always get them confused. So those of you who are federal, you'll go first. The state ones, we need you for the floods and everything. That's important too. Do you guys deploy as the state? Like, do you still deploy? Okay. So it's not just for you. Do you guys go first or second? Do you know? Just depends? Okay. See, I'm trying to learn more. I'm debating when I can retire if I should like shift over, like I have my 21 years and then like still do it because I love wearing the uniform, but I want the ones that won't deploy as often because I love my family and I've done 21 years, so I gotta figure that out. All right, anyways, I digress. E-Fast, finally. We've been talking about it all this time, we're finally gonna go over it. When do we do it? Trauma. Acute, blunt, penetrating, chest or abdominal trauma, trauma in pregnancy, pediatric trauma, subacute torso trauma, undifferentiated hypotension, probably because they're bleeding from trauma, and we don't know why. Trauma. All right, there we go. What are we going to see? Blood in areas it's not supposed to be. That's the gist of it, right? Hemopericardium, so blood in the pericardium. Yeah, sometimes we can see the pericardial effusions. We can see the hemoperitoneum, so blood in the peritoneum, fluid in there. The extended fast, that's what the E stands for, is extended pneumothorax and hemothorax that we talked about already. Here are the different areas that you are going to be looking for when you do your fast exam. You will learn how to do this senior semester. You will do this on each other. Okay? We have our chest areas for our pneumothoraces. It's not just one area. You're going to go up and down like we talked about. That's one. But then you have your right upper quadrant, your left upper quadrant, your subxiphoid for the heart, and the suprapubic for the bladder. 1, 2, 3, 4, 5 if you're doing the extended one for the pneumothorax. Right? How do I know which side to do it on? I did a physical exam and I heard decreased breath sounds on one side versus the other, or absent breath sounds. That's where I'm going to go ahead and do it to verify. If I have trauma on the left side and echinosis, then I'm going to do it on the left side. If I don't have trauma on one side, I'm not going to do it on that side. If I have it on both sides, I'll do it on both sides. It just depends on the patient. Okay. Here are your normal E-fast pictures. My right upper quadrant. So what organ is on the right side of my body? Liver. What is this? Kidney. Liver, kidney. See how they hug each other really nice? I like that. I want them touching. If I have, what's in the bladder here? Fluid. If I have any fluid in between the liver and kidney, that's positive exam. They should be hugging each other super nice, and there's my little line that does it. Okay? So now if I go to my left upper quadrant, I recognize there's a little shadow there, but what organ is this? Spleen. What do we got here? Kidney, hugging each other. They're friends. They're snuggling on the couch, getting ready to watch a movie. I should have nothing separating these two. No fluid, no little toddlers trying to cut in between mom and dad while they're trying to watch the movie, right? There should be nothing in there. That line right there, they should be hugging each other. That's normal. We'll see what abnormal looks like. We'll go normal first. Subxiphoid view, which means subxiphoid means we're looking at what? Heart. But this isn't my M mode, right? I'm just looking at the heart. I'm not looking to evaluate the valves. I'm not looking at the functionality of this. I'm looking for fluid. I'm looking for fluid within the pericardium. Here's my pericardium, right around the heart. Nice part about the heart view is I can see the chambers, I can see the septum, so I have an idea of where that pericardium is supposed to be. If I have all my fluid is within the heart, if I have an area of tissue and then fluid and then another line of tissue, that's going to be fluid in my pericardium. That's abnormal. We'll see a picture on that as well. Same thing with the bladder. What's this down here called? What do we call that? This bright white area? The posterior acoustic enhancement. Right? It is hyperechoic compared to the bladder, the fluid in the bladder. That is true. It is hyperechoic when you compare it to this area. But that's that posterior acoustic enhancement because the bladder is full of fluid, and so we end up getting that. Again, normal shaped bladder, that's great. If the bladder is funkily shaped, or I got some, funkily, there's a word, or I got some fluid sitting in the outer areas, that is positive. All that fluid should be within the bladder. Those are my normal EFAST images. Here are some abnormals. You see the toddler separating mom and dad trying to watch the movie. They are not buddies anymore. Something has gotten in between them. Is that blood? I don't know. Most likely, but I don't know because all fluid is black on ultrasound. I just know this is a positive EFAST. Does this mean that there's injury to the liver or the great kidney? Not necessarily. That could be from anywhere. But now I know that they're likely internally bleeding because I have fluid where it's not supposed to be. Same thing with my left upper quadrant. That's a lot here, but these should be touching. I got free fluid in between the kidney and the spleen. You'll go over like what they're actually called in other classes, like the Morrison's pouch and all that kind of stuff. We're not going to hit that here. I need you to recognize normal from abnormal. So when you do these exams, which you will in your career, this is something that you'll be like, okay, good, 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 good. So I need you to be able to pull out the ones that are abnormal. Here is my pericardial effusion. Right here. And also kind of right here. So here's the edge of my atria, my ventricles. Look at the wall of my ventricle. The pericardium is supposed to basically be touching right up against the ventricle. If we look at our normal one, we didn't see a difference between the pericardium and the ventricle. It was all like one kind of wall, one cardiac muscle wall. But now I got fluid outside of the heart sitting right here. That's abnormal. And then my bladder. Bladder can take different shapes, right? It can take different shapes, especially if it's ruptured. Look, it can take different, but I have fluid outside the bladder. What's that from? I don't know, but they're bleeding. So, if you learn these and you learn what normal looks like, commit that to the memory, then you'll be able to find the abnormal image that leads you to think a positive EFAST. This is one of the few cases that I would say you don't have to use Radiopedia. Google is completely appropriate to look for abnormal EFAST images. Okay, that's actually one of the few things that it's really good at. X-rays, there's a lot to interpret, but for this, no pun intended, it's pretty black and white on whether or not it's abnormal or normal for EFAST. So Google is a safe bet when looking for normal EFAST versus abnormal EFAST, if you're interested in doing that. There's not much gray area for interpretation. Here's some extra resources if you want to kind of dive a little bit deeper. A step-by-step guide of how to do the EFAST. POCUS is point of care ultrasound. You will learn that your senior semester, so if you want to kind of take a look and understand the positioning and how to do it and kind of put in your mind the anatomy and why we're looking at what we're looking for, these guys will kind of help you. Okay? Questions on the EFAST stuff? Okay. I'm going to stop there for today because I do not want to start to get into COPD with only like 5 minutes left. All right? So, this is it. Tomorrow we finish the chest. We will slowly get into the abdomen. We're almost done with the 8 million different things that we can see in the chest. As you're studying, try to make yourself a chart or make yourself something that helps you understand what are the different nuances to these disease processes when I see them on X-ray. If I see them, how do I know it's one or the other? Help kind of learn it that way to help you distinguish between these things. And if you have any questions, let me know. I'll hang out for a few minutes, you guys. Good luck on your test tomorrow.